Welcome to presentation on substance use in adolescents and prevention and treatment. We are joined by Dr. Savage. Dr. Savage works at UAB and with Children's of Alabama and has a substance use clinic that's specifically focused on adolescents. So she has lots of great information to share with us today. But first, I have to go through some housekeeping stuff regarding continuing education. So let's see here. All right, so this event has been approved by the Alabama Board of Social Work for 2 contact hours and the NBCC for 2 contact hours and the Alabama Board of Nursing for 2.4 contact hours. So in order to get your certificate, what you are going to have to do is fill out an evaluation at the end of the presentation. The evaluation link will be dropped in the chat box. And then you guys should also have had to register when you came into Zoom. That's something new that we're trying just to make sure that we get all the correct emails to get certificates to folks. So that is the email list that I will use to make sure that everyone gets their certificate. So certificates will be out hopefully within 7 days. We are a small nonprofit, but we are very busy here at APC. But I hope that they're out to you guys by the 18th. Usually try to have them out by the end of the week. We have a presentation midweek. But if you guys have any questions, an email to reach me at is ce@apcbham.org. All right, so like I had explained a moment ago, when you complete the evaluation, in the past, you've had to click on a link that will take you to the CE request form. Hopefully, if you've joined us via Zoom, you've actually already had to do that. But for some reason, if you did not have to do that when you initially logged into Zoom, please be sure to click on this link here, and I'll pull the report and get your email and information from there. All right, and I just want to give a shout out to our sponsors for this presentation, the Drug Education Council, which is located in Mobile, Alabama, the Addiction Prevention Coalition, which is where I'm at here in Birmingham, Not One More Alabama in Huntsville, and then the UAB Center for Addiction and Pain Prevention and Prevention, which is CAPI, which is located at UAB. So, Dr. Savage, you now have the floor.
All right. I hope everybody can hear me. I've got my ears plugged up with headphones, so it's like I'm hearing myself talk very clearly, but hopefully you guys can hear me too. Thanks for having me, Ashley, and APC, one of my favorite groups in this city, because they're doing such great work, and so many other partners, all of you guys too, are doing awesome things to help our teenagers and our young adults, which is the population I sort of focus on. So I appreciate all the good mornings in the chat too. You know, I give talks to a lot of medical people here, like residents and sometimes in medical school, but they're not as like open and chatty in the chat box as you guys are. So I'm really happy to see that. It's odd to be given a virtual talk still here, but I hope at some point I can meet you guys in person for a talk maybe in the future. Let me share. Ashley Loftus knows that I get chatty sometimes, so and I need to focus on the top. Say share screen. Oh, what do I do? It says the host disabled screen sharing. Ashley.
Oh, hold on.
Okay.
Let me pop this up here real quick.
Okay.
Okay, let's see. All right, you should be co-host now, so it should allow you to share your screen.
Gotcha. Yep. Thank you. Alrighty. And again, Ashley, you're gonna tell me if something doesn't look right? Okay. So can you guys see the slide?
Yeah, but you may want to go to the top where it says start from beginning, and then it'll make it full screen for everybody.
Yeah, you're seeing the notes slides, like the presenter slides, is that one?
Yeah.
Okay, how do I change that? I'm sorry, y'all. How do you change it out of presenter mode? Does anybody else know?
Okay.
I have a double screen on that's part of the issue. A display settings. Let's do that. I swap. Now, is that better?
Okay, yes, that is perfect.
Okay, sorry, technical difficulties as always. All right, so we're going to talk about substance use disorders in adolescents today, prevention and treatment. And so let me make sure everything's working. Um, I have no relevant financial relationships. I always have to do a disclosure slide working here, but I will be talking toward the end of the talk about off-label use of some pharmaceuticals for adolescents with substance use disorders, because a lot of those are not FDA approved for under 18, but we'll get into that at the end. All right, here's the objectives for the talk. So first we'll describe why substance use impacts adolescents differently than adults. We'll discuss how to identify substance use in adolescents, review risk and protective factors for substance use. That's the first half of the talk. And then we'll take a break. And then in the second half, we'll use cases to review common substances used in adolescents and management plans that we come up with in clinic. And I'll describe my clinic in just a minute for you guys. And then lastly, we'll go through kind of how to make planned treatment for young people who have substance use disorders. And that always includes family involvement, which can get quite tricky, as many of you probably know. But family is so important to adolescent treatment and just all parts of adolescent care. We'll also talk about medications and how MAT, or medication assisted treatment, can help in adolescents as well, which is an area that's I don't think is underutilized, I would say.
Hey, Dr. Savage.
Yeah.
I hate to interrupt, but several of the people are pointing out that there is an echo
Oh no.
with
Oh
the
me.
audio, so you may have to take your headphones out and just use your computer.
Oh, okay. Yeah, I'll do whatever is best. Can y'all hear me? Can you hear me, Ashley?
Yeah, I can hear you.
Is it echoey still for my friends? Because I can't see the chat.
It is not echoey on my ends,
Okay.
but
Okay.
everybody else hears an echo. Okay, yep, they said it's much better.
It's better. I'm sorry. I told Ashley I didn't bring the headphones that had the mic, of course. I brought like 3 other pairs. Anyway, so I was using kind of a weird pair of headphones. So maybe that was it. Okay, so I'm going to give you guys I have one slide just as an overview of what my patients and a lot of your patients and your clients might look like or sound like. One is a 13-year-old who presents with anxiety and has panic attacks. On further questioning, he admits to vaping a disposable vape pen daily for the last 6 months. His mom is not aware that he's vaping when you talk to her separately, and he has no interest in cutting down. A 14-year-old comes in to the clinic after a hospital admission. She was coming in for a follow-up visit. These are my real patients, by the way. I didn't make these up. She was admitted to the hospital for 2 days after she took alprazolam, which is Xanax, vodka, and baclofen together. She was just experimenting. She was not trying to kill herself. Otherwise, she uses cannabis edibles and she vapes daily. And then a 17-year-old presented to the hospital at Children's after being found down at home, and he responded to Narcan on the scene. But he came in the hospital for admission, and he started to sweat, be irritable, and essentially go into withdrawal and wants to leave the hospital against medical advice. So it sounds like a mess, right? But really, what I'm bringing out with this slide is that these are like our young people, that they're not defined by their stories and their these unfortunate things they go through, but they're people who have futures, who have goals, we're trying to mold and form into adults who are vital parts of our society and have important futures. And I know that I just want us to think of these young people as individuals who are each have a path that are chosen to do something important, and not as a story and a difficult case to figure out. So sometimes I get bogged down in I've got to figure out what to do next, instead of thinking about like the individual and how to help them reach the goals that they need to reach. These aren't all their actual pictures, but one of my patients was willing to share her picture, who's now in recovery. knowing that I was giving a talk. And she's doing much better, but this is her here. So, part one again, we're going to talk about how adolescents are special and must be treated differently. They're not just little adults, they're not just big kids, they're very developmentally in a special place. We're going to talk about how prevention is key to improving health and decreasing drug use, and how we have to ask about substance use and drug and alcohol use, but we have to ask it in the right way, and we have to ask it in a confidential manner. Um, so I'm going to spend a little bit of time on this slide. It's like a very, brief bullet point overview of what to know about adolescence. But, adolescents are different for many reasons, but one of the main ones is because they have developing brains and bodies. So everybody knows, it's a period of transition physically, socially, academically. With the increase in development, or the changes in development, adolescents start to take risk-taking behaviors. Um, Mental health problems emerge. By the time kids are 14 years old, more mental health problems are popping up, and actually suicide is the second leading cause of death for ages 10 to 24. So it becomes just a different time in life that we're having to think about brain development and these changes happening, right? So risk-taking behavior comes about from different brain pathways, which I'll get to on the next slide. But it's also important, like peer interactions, family interactions start to change, and young people view family differently. While they're important, it's like their peers become more and more important as well. So you kind of have to navigate this whole psychosocial situation carefully, and it's different for every teenager. So I did have this bullet about confidentiality because I don't talk about it much elsewhere in the talk, other than if you have questions about it in the cases, that might be a good place to talk about it. But confidentiality, the way we approach it in clinic is, when teenagers come into clinic, we're like a pediatric and adolescent clinic, so we do general care, like we just do checkups and physicals, and if you get hurt or you're sick, you can come in. But we also, in my clinic, get referrals for substance use problems or eating disorders or all those kind of specialty type issues. And all the patients, when they first come in, we're supposed to give them a discussion about confidential care and how we're going to be discussing things with you and asking you things that aren't necessarily always shared with your parent. Like, I want you to feel comfortable telling us the things that you feel, knowing that we're not going to immediately share everything you say with your parent or your loved one that's with you. But if you tell us something that's harmful to you, like you want to kill yourself, you want to hurt somebody else, or you're harming yourself or doing things that could be harmful to you, then we may have to share those. So that's sort of the way I frame it and sort of our policy around it. We interview just about every adolescent separate from their parent. It takes a lot of extra time, but it's so vital because you get such, it's interesting. You get different information a lot of times from teen and parent, and then you have to pull those together. But that time separately is so important to understand what's actually going on and where their mindset is. And so we talk about this a lot in pediatrics, but just the importance of confidentiality and taking care of teenagers. And I can get more into that later if you have questions. And this is what I'm talking about the brain, the adolescent brain. So there's a reward pathway here that, looking for my pointer. Okay. A reward pathway here in the center of the brain that is very active in teenagers, like overly active. It's not as active as like mine, for example, where it's very responsive. What I'm trying to say is that it needs more of a stimulus to really get vamped up. So that's why risk-taking behaviors are sort of normal in teenagers, because they look for things to like activate this reward center. I call the reward center this circle here between the nucleus accumbens and the ventral tegmental area, VTA. I call this the gas pedal, okay, in the teenage brain. The brakes are up here in the front, the pink part called the prefrontal cortex or PFC. My little girl has a book about the brain, and it's like one lady's name is PFC, and she's the one that tells the kids to, calm down and think through things. But the prefrontal cortex is the executive functioning, right? It's the frontal lobe that we all hopefully have developed as adults. You don't fully develop it until 24, 25 years old. So, and that's been shown in MRI studies like this, where they find that like this frontal area of the brain, this is the front of the brain, this is the back of the brain, this is looking at the brain from the side. Whereas you move down, you see like the green areas are the areas that take longest to turn blue, or is the prefrontal cortex, and it's still got green in it around 20, 21 years old, which means it's still developing, still pruning, all the things that neurons do, the myelination and maturation of the brain. So I preach about brain development to patients and parents all the time. And I know you guys have probably heard all this if you work with teenagers, but um, the prefrontal cortex is the brakes of the brain. The reward center is the gas pedal. These kids, like all adolescents, their reward center is ready to go. It's looking for different stimulation in terms of risky behaviors, but that prefrontal cortex is not thinking ahead very well. Like, wait, if I do this, then like if I drive after I drink this alcohol, then that could lead to me having a wreck, and then I might get either hurt somebody, hurt myself, I might get a legal charge, I might, they're not thinking through all the consequences appropriately until they're older. So we have to work in this setting. That's another reason why parents, again, and family are so vital to teenage care, because even without substances on board, you can't rely on a teenager to think logically through risks and consequences of their own behavior. Um, so that brings us to the next slide. That's like I'm setting it up to explain why teenagers are already at high risk for risky behavior, but when you add substances to the brain that's still developing, they have a much increased risk of addiction the younger that they start. So the takeaway here is that 90% of adults, probably over 90% of adults who have addiction problems, started using alcohol, tobacco, or drugs before age 18. So that's why it becomes important that we talk about this in the early years. Here's another example of how age matters. So this chart comes from the National Survey on Drug Use and Health, which is a survey given to high school students. This was done in 2018, so it's been a few years, but it's the trends have always looked similar. The likelihood of an alcohol use disorder is a function of age at first use of alcohol. Okay, so your first use of alcohol, the earlier it was, if it was 12 years old, 13, 14, this is the percentage of those individuals that have an alcohol use disorder as an adult. So individuals who began drinking at an early age have 5 times higher odds of developing an alcohol use disorder than those who started after 21. So this chart's the same for marijuana. This chart's the same for opiates. This is why we talk prevention. This is why people like Addiction Prevention Coalition exist, is because we're trying to prevent substance use problems before they start. And if we can delay onset of alcohol and substance use until later in life, then the risk of addiction and substance use disorder drops substantially. And that's kind of where prevention comes from. So these slides are all about why prevention is important and actual like data, like there's actually, we've looked at why this matters, right? So I like the cannabis example, and I wanted to pull this in as the example because I talk about cannabis so much, or marijuana, THC, however you want to say it. We talk about this a lot in clinic because Ashley works with me in clinic a lot, and she knows, I mean, we have so many kids out there who use cannabis because of kids are seeing it. It's been legalized in many states. There's a perception that it's safe and healthy, even. So that leads to more use, and that's across the board for any substance over the years that has been legalized and viewed as okay in adult world. However, this comes from a New England Journal of Medicine, which was one of the major journals in medicine from 2014. And Nora Volkow is the director of NIDA, National Institute on Drug Abuse. Um, and and it's just a table from the paper, and it just lists adverse effects of short-term use and long-term or heavy use of marijuana. And effects of long-term or heavy use: addiction, in 9% overall, 17% of those whose use began in adolescence, and 25 to 50% of those who are daily users. So this is bringing home the point again from another person who's much smarter than me who wrote this paper, that, you know, and you look down here, the effect is strongly associated with initial marijuana use early in adolescence. The earlier a teenager starts to use marijuana, the much higher risk they are of addiction to it, and then the much higher risk they'll continue to use as an adult and have a substance use disorder because of it. So again, if we can educate our families and teens about this, that they're at high risk, and it alters brain development, and there's more poor educational outcomes, high risk of dropping out of school, more risk of a lower IQ later in life. Even if they stopped using as adults, they only used frequently as an adolescent, they still had lower IQs as adults. There's a lot of problems with cannabis in the teen brain. And I frame it that way. You'll have kids say, well, how come so and so state legalized it for? And I always go back to, that's in adults, you're an adolescent. You know, let's talk about how your brain is different than an adult brain, and why and I tell this to the parents too, you know. And then I also talk about high risk of chronic psychosis, which we're seeing more and more. And psychosis is seeing things that aren't there, hearing things that aren't there. Schizophrenia diagnoses are increasing, and much of it is due to higher concentrations of THC in cannabis. So I'm using cannabis as an example to explain how brain development plays in to risk of addiction and into substance use disorders for teenagers, and sort of how to frame this around teen development, how to talk to people about this. Okay, other reasons, things that I feel like you guys all know this, like hearing about what backgrounds are here today, but reasons why prevention matters. I don't think I have to tell you guys this, but this table is a table that just laid out all the negative consequences of youth substance use from a really cool resource I found recently, from drugfree.org, called Rethinking Substance Use Prevention. It's multiple pages long, but it's got a lot of good information about prevention in it. And you know, these are just the consequences of youth substance use. So things you guys know: again, declining grades, truancy, school dropout, unemployment in early adulthood. The mental and physical health problems here are getting at what I've been talking about, right? Maturity, brain maturation is halted if you're using cannabis daily, for example. And that's just how I describe it. I was like, I ask a lot of teenagers, when did you start using marijuana? And then when did you start using marijuana anywhere close to every day? And then you can just imagine your brain is just sitting at that stage of development. You know, I might be talking to a 17-year-old who started using daily at 14, and their brain is just still functioning in many ways like a 14-year-old, because of that substance being there daily, and how that's changed their brain and altered its development, impaired the development of it. It goes along with a lot of comorbid mental health disorders, and we'll get into this with the cases, but anxiety, depression, PTSD, suicidality, self-harm, you know, all of these things go along with substance use, and they either, whether they've happened before, during, after, you know, however it plays in, they all influence each other. And substances for sure make anxiety, depression, things like that even worse, and they certainly decrease the effect of any medications that that patient may be taking for their anxiety or depression, which is another teaching point for families. We all know that driving, things I've already talked about, driving under influence, like increased risk of dangerous behaviors, happens. Unprotected sex and unplanned pregnancies, violence, all these things happen as well as a result of youth substance use in many cases. Motor vehicle fatalities, suicides, you know, so many problems related to youth substance use. So I go back to this, and I give a talk like this a lot for my pediatricians, and I just recently gave it for the American Academy of Pediatrics, to try to reframe substance use as a pediatric problem, as a kid issue, as a youth issue. Again, that's why I love prevention groups so much, like the APC. So, and I love the fact I saw many of you probably work in schools. I think that's a huge target, like meaning a place we can target prevention work, and we already do. I know target prevention work because the kids are there, and that's where they are the majority of the day, and that's where they can get education and care. And so I know a lot of you probably work in schools, and so I appreciate what you do. Um, those who research or practice in the field of substance use and addiction have directed most of their attention toward adolescence because this developmental stage represents the height of vulnerability for experimentation and with initiation of substance use and for the consequences of that use, including the risk of developing addiction. So this is from the Partnership to End Addiction as well. All right, let's keep going. So a few slides here on substance use in Alabama, what our kids use, and then and how to ask the question and with screening tools and just different concepts there. So the Youth Risk Behavior Survey done in Alabama, the last time I know of this was done was 2019. It might have been done in 2021, and the last I looked, I couldn't find that for Alabama. I couldn't find the data, but the last I had was 2019. So looking at the top 3 substances used by our teenagers, which are nicotine. N stands for electronic nicotine delivery systems. So this is nicotine, alcohol, and marijuana. Nicotine. So over half of high schoolers. So when you put 9th through 12th grade together and you look at the total percent, over half have ever used an electronic nicotine product, and 1 in 5 had used in the past month. So again, that's all high schoolers taken together. This number, 20%, is more like 30 or 40% of 12th graders when you look at just seniors in the past month. So nicotine definitely is a culprit in our teenagers. Alcohol. So again, almost 25% reported drinking alcohol in the last 30 days, and that's of all high schoolers. I think that's pretty high. So but almost 1 in 4 said in the last month they had drank alcohol. Now, 17% had their first drink before age 13 is what they're reporting. Again, this is Alabama youth who said this. Marijuana, 30% had ever used in their whole life of putting all high schoolers together. 15% of all high schoolers had used in the past month. And then looking at prescription medications, because this is where we see the most fatalities from overdoses and a lot of illness, serious illness, is with prescription opiates or sedatives like Xanax. 22% have ever misused opioid pain meds, and that's of all high schoolers report that. So those are the numbers for y'all to know. This is another way to look at national numbers. So it's a lot here, sorry, but this is the percent high school seniors who used in the past year these things in the US. So you look again at the top ones are alcohol, over 35% nationally of seniors say they used in the past year. So you have to look at the time frame and everything, but you'll see that seniors who got drunk were almost 20% in the last year. So, and this just tells you more like marijuana is about 25%. Vaping marijuana is on the rise, as you guys probably know. I'll talk some about that. Cigarettes are lower on the spectrum than vapes, as we all know. And then these are the other things like narcotics, hallucinogens, amphetamines. What I don't see on here is sedatives, but maybe that's under narcotics. Just wanted to give you all national data for seniors there. That's for monitoring the future. So I wanted to hit some risk and protective factors. I know you guys, if we're talking about prevention work and we're talking about adolescents, and coming from a public health perspective too, which I know, again, a lot of you probably have that background, I see the chat filling up, so I hope maybe at the end of this we'll talk some about what y'all are saying. Sorry, I can't see it at the same time, but risk and protective factors. So let's talk risk factors right here at these. They're called the socio-ecological levels, which I know some of you probably heard of. So every person, every individual lives inside of sort of these concentric circles. So there's like Becca, like me, and right now I live inside of my family. I have a husband, I have 3 kids, my mom, my dad, that's my family. And then outside of that, for kids, is their school. Maybe for me, it's my workplace. But kids have that next concentric circle of school and their school environment. And then even out broader than that is their community and the town, the place in which they live, their neighborhood. And the biggest circle is the sort of the nation, the country, the policies under which they live, the law under which they live. So everybody lives in these circles of really prevention opportunities, I'm going to say. So everybody also has different risk and protective factors at each level. And so in any individual person, any individual teenager who like begins using alcohol or drugs early, any individual teenager who already has a history of mental health problems like ADHD or conduct disorder, those are 2 biggies for also having high risk of substance use. Um, that's an individual risk factor for that person. So again, early age at first use, mental health problems like ADHD, a history of trauma, certainly a family history of it says genetics, but it just means family history of addiction increases one's risk a lot for substance use. And then that individual's attitudes or beliefs. So those all can put a patient at risk for substance use. On the other end, like an individual can have a lot of protective factors to prevent substance use, like if a young person knows that vaping is bad for their lungs, and I play soccer, so I mean, and I could tell when I vaped I couldn't run as fast as so and so I don't want to vape anymore. So I hear that a good bit, that they know it's risky for their health. That perception is a protective thing, right? If they have autonomy, they're like, I got, they're independent about that. Like, I don't care what this friend's doing. I know I don't want to do it. And they have self-efficacy, then that's also going to protect them from using substances. School-based extracurriculars, almost for across the board, um, are protective because I think it's because they keep patients busy. They add other factors in their life, like other positive adult role models, and things like that are the reasons why. And they have a goal in mind to do well in some activity. I think those are the reasons why they protect adolescents from substance use. So let's go to the next circle out is a kid's family. So if you have a parent who is using drugs or alcohol, and this comes up a good bit with our kids, with both marijuana, with alcohol, with vaping, with all of it, if their parent uses it too, then it's going to be really hard to convince the kid that they don't need to. And that requires a lot of education with the parent. And again, and I bet you're thinking, well, how in the world do you talk to a parent who's like, has alcohol in their house and they're drinking a wine every night? I just heard a kid tell me last week, who has an alcohol problem or had an alcohol problem, is doing better. She's back from a different treatment program. She also has an eating disorder. It gets complex, right? So she's back from an eating disorder treatment, and now we're back to preventing any future alcohol and drug use. She's like, oh, it's all in my house, and she talks about how, well, my mom has a glass of wine every single night, so she ain't gonna give that up. And those are the words that came out of her mouth when she was 14. So, so I talked with their parents separately about like how important it is from from for her health, for the patient's health and well-being, and to give her the guardrails she needs to do well and to keep going going toward her goals without any risk of substance use, for them to rid the house of anything that is substances, including alcohol. And so I have this discussion with parents in a sensitive way where they can understand this is about your child's development and health and improvement. And so when we frame it that way, I think parents hear it differently. It's all about your child being healthy and safe. Okay. I'm not talking about you right now. I'm talking about how to make their environment the best place for them to succeed. So, altered family structure, you guys know, like families who are broken, families with divorce or different problems and discord, that increases risk of substance use too for various reasons. I'm not saying any specifics. I'm just saying that it correlates with substance use in teens. So on the other side, protective factors for substance use would be parenting style, warmth, high monitoring, which I'll talk about at the end again. Parents clearly laying out expectations from before things get bad, for lack of a better way to say it. Like, and this might come down to, again, prevention in terms of educating parents before problems begin, which is tough, right? A lot of us, including me, are more like reactive instead of proactive about a lot of things. And so educating parents ahead of time through schools and things like that, and things that schools are already doing, I think, about how to lay out clear expectations for your child to know, like, if this happens, like, I know these things are happening in your school. If this happens with you, then these are the things that we're going to have to do to make sure that you're staying safe and healthy. Or even more basic than that, as if you live in our home, these are the expectations. I expect you to get up in the morning, get ready to go to school. I expect you to, at the end of the night, your cell phone gets plugged up outside of your room. That's a whole other discussion, which cell phone use in these kids. But or I can, I expect to be able to look at your phone, at your social media. I expect you to eat dinner with us together as a family. That you don't stay in your room and eat. Like, I don't, parents can lay out different expectations before there are any behaviors that start creeping in that become problematic. And that helps a lot, I think, protect young people from getting into substance use, for example. Um, Okay, the next circle is the school and peer kind of circle. So if a young person's peers use drugs, they're at much higher risk, of course, of using versus peers who don't. So that was just one very, and these are not, by the way, all encompassing. There's like pages and pages of risk and protective factors, but I'm just pulling out a few. And then community risk factors, like if law is not enforced, if you have nicotine, vape shops, CBD shops selling to youth without checking their age, same with alcohol. I mean, I hear it all the time. I know y'all do too, about certain shops in certain places in the neighborhood, so and so never cards. So I get it all the time from that or this or that store. That's a big risk factor versus if it's less available and laws are enforced appropriately, it's harder to get. So there's a reason why we set legal limits, like for alcohol, for example, at 21, um, because policy wise, they found that, like, if they did, the younger the age that alcohol became legal, the more motor vehicle crashes we were having back when all these laws were made. So they found that the best cutoff was 21, and that's why it's there. But that's just a law thing that has actually decreased alcohol use in young people just because it's harder to get. Um, okay, that was a lot. I hope y'all are still with me. That was a lot on that slide. We've sort of already talked about signs of drug or alcohol use, but things that you guys know are if a young person comes into clinic with me for just a checkup, so there's no concern for substance use initially, it's just we're checking up, and they say, oh, my grades are worse for the past 3 months, I'm failing this and that class, or oh, I decided I'm going to quit baseball now, and now I've played it for 3 years and I really liked it, now I'm quitting. These are all sort of these red flags that wave in my brain, where I'm asking more questions. Like, it might not be substance use, but it could be you're depressed, it could be something's happened in your life, something traumatic has happened. It's just red flags that we need to ask questions. um, Sleep problems, multiple somatic complaints, meaning kids who always complain of headaches, always complain of belly pain, and it's happening chronically, and they've had like a doctor visit and nothing necessarily can be found. Those type complaints happen more with mental health concerns. Um, I'll talk about this later, but with kids talking about trouble focusing, irritability, anger, I'm biased because I see a really severe substance use in my clinic, but I'm asking about drug and alcohol use all the time with those kids because a lot of them vape nicotine and they, first thing in the morning they wake up, they haven't vaped since 9 o'clock or 10 o'clock the night before, and they're withdrawing because they vape every day, all day long. So, asking about these things is important, and remembering all of these factors to ask about drugs and alcohol when kids are coming to you with these complaints. So how to, screen for substance use in teens? And I just bring this up because I think it's important to know what screening tools um, are validated for teens. And there's two. The S2BI is one that among medical people they've recommended. Um, and then the craft is another that I know that you guys have heard of, or many of you probably, because I know they use the craft in the state mental health assessment, things like that, I believe. And a lot of other clinics use craft. So craft, they've revamped craft recently to make it a 2.1 to have nicotine on it, so that's really important. And I'll show you that. And there's this other nicotine withdrawal assessment called the honk. It's kind of a funny name. It's like hooked on nicotine. I can't remember what the C is right now. Hooked on nicotine something. And it's like a 8-question thing that if you score positive on any of the questions, you probably have nicotine dependence to some degree or withdrawal. So this is really busy. I'm sorry, but I would just screenshot the craft 2.1 plus N. So it tells you kind of how to ask the questions, and this will be if you're asking verbally, but you ask about past 12 months. Part A, during the past 12 months, on how many days did you drink more than a few sips of beer, wine, or any drink containing alcohol? And you put, ask about alcohol, you ask about marijuana in all its forms, you ask about anything else to get high, and you ask about use a vaping device containing nicotine or tobacco products. And so then if they answered no to everything, you just ask the car question. Have you ever ridden in a car by someone, including yourself, who is high or using drugs? Otherwise, you don't have to ask anything else. Like if a young person says in the past 12 months I've used none of those things, you really don't have to ask any other questions other than car. But if they say yes to anything, essentially, then you ask the entire craft. And I think most of you might have heard of the craft. I know if I was in a lecture room, I'd get you to raise your hand. But this is a craft. I'm sorry it's tiny, but you can just Google it too, and it's a free. I got this free PDF online, but um, it's a car. Have you ever ridden in a car driven by someone? Like I just said, do you ever use alcohol or drugs to relax, feel better, or fit in? Do you ever use alcohol or drugs while you are by yourself or alone? Do you ever forget things you did while you used alcohol or drugs? Do your friends or family tell you need to cut down? Have you ever gotten into trouble? So, all these bolded are the stand for craft. Okay. So here's the scales thing that's important to me. Like I have kids in clinic fill this out, and if they screen positive, that's when we get more people involved to help them. The cutoff they've made is 2 yeses. So if they circle 2 yeses or more, um, they they have a higher risk of a substance use disorder, a DSM-5 substance use disorder. And you see how the higher the craft score, like if you have a craft score of 5 or 6, then the probability of a substance use disorder is like 100%. So that's the craft. This is the S2BI. Don't get bogged down in all this down here for a second. If you'll just focus up at the top, in the past year, I always tell my colleagues, like, always ask a time frame. Don't just ask a kid, have you ever smoked or have you ever vaped? Or the same goes for sexual behaviors. Honestly, if you say, do you have sex? They'll say no if it wasn't like yesterday or today. So just ask like very specific questions. So they found you have to say in the past 12 months have you, or how many times have you? And the first things asked about are the top 3 substances in teens, which is tobacco, alcohol, and marijuana. Tobacco meaning vaping, nicotine devices, because most kids do not smoke cigarettes, they vape. So if they say no to all three, the top 3, then you just positively reinforce that and move on. So this is again for a medical clinic approach. But I'm just making the point here that if they say no to everything, you positively reinforce that. You don't necessarily have to ask more questions other than maybe the car question, like on the craft. But if they say, yeah, once or twice I drank alcohol in the past year, well, or any of them, if they say yes to any of it, you technically then should ask about prescription drug use or anything else to get high at all. And then give advice and then follow up. So again, don't get bogged down in the bottom part of this because that's not my point right here. My point is to ask the question the right way. And this piece here, frequency of use, this is a big takeaway. I hope everybody's still with me. We're about to take a break. Frequency of use is the most important question to understand how severe the substance use disorder is. So, so if they've used once or twice, they probably don't have a substance use disorder. If they've used monthly, they probably have a substance use disorder. Weekly, they probably have a severe substance use disorder. So you can imagine that daily use is definitely correlates to a severe substance use disorder. And substance use disorder is from the manual, that psychological manual that called the DSM-5 that outlines the criteria. And there are 11 criteria, and I've grouped them into different areas. But this is what I'm talking about when I talk about substance use disorder. It just is marked by impaired control, social impairment, risky use, and then having pharmacological changes like withdrawal when you don't use or more tolerance to the drug. You only need 2 of the 11 criteria here to have a substance use disorder that's mild. So what I just said a minute ago is that if you have any client or patient using a substance daily, it's strongly correlated with multiple studies that that's a severe substance use disorder, because you can imagine that that's interfering with multiple parts of their life. They've got tolerance and withdrawal if they use daily, and they're taking a long time getting it or using it. So I just wanted to throw up this slide, even though most of you probably have heard of this and know about it, but I'm using substance use disorder, that term, a lot, and it comes from the DSM-5. It's the new term for substance abuse, which we shouldn't really be saying these days. Abuse is out of vogue now because of stigma and things like that. So here's my summary from part 1, and we're going to take a break. Sorry, 1 second. I'm getting like blown up with my pager over here, and I'm not sure what's going on. But the summary for part 1 is that adolescent brains are more vulnerable to addiction and substance use disorders. It's just the big takeaway from the beginning. That prevention efforts led by us, by caregivers, parents, counselors, schools, health providers, prevention efforts that we lead can decrease youth and adult substance use. And again, I've also talked through how to ask the questions and how to get information. So now's when I'm breaking, because this is part 2. We'll talk through cases, but I will be quiet for a moment and let Ashley take over.
Hey.
Hey.
Okay, you were doing an amazing job. We have one quick question in the chat. This person is asking, if an adolescent stops smoking marijuana for a year, will that help their brain development? In other words, if they started at 13 and stopped for a year at 16, will their development be more like a 14 or 15-year-old after that year? And can they catch up?
Oh yeah, I'd say it's hard to get in the nuances of like exact numbers, but in general, the longer that they're abstinent and stay away from it, the better. And yes, catching up, like I wouldn't say, I told you that I frame it that way to teenagers. Like, listen, ever since you've been smoking daily, you just imagine your brain's been in like no development mode, like hibernation. It's not pruning, developing, it's not forming memories normally until you stop. using daily, and it needs and some kids think, okay, well, I can still use every week or on the weekends. It's still going to alter the development. I would say the more you can get the marijuana out of the brain, the faster the pruning and the synapse changes, the faster they'll start waking up and normalizing. So the longer you can go without it, the better. um I don't think I can put it into like exact time frames. Do you know what I mean? But I would say, like, yes, every adolescent can catch up, but you guys all know about, like, there's 18, for example, like 18, 19-year olds who are quote adults, but they've been using a substance for 4 years. They're not functioning cognitively like an adult. And I think a lot of that is the substance use, not all of it, is the substance use impeding memory formation, cognitive development, all those things that are not happening appropriately because the substance is tied up in all those connections, and they've had that in their brain so long. So you have to think about even your 18, 19, 20-year olds, sometimes in the context of an adolescent, cognitively. They might not look like an adolescent, and they certainly might not act like one in some of their behaviors, but or they do, but you know what I mean. But what I'm saying is, like, we have to, like, frame things around if kids have been using most of their teen life, and just because they're 18 doesn't mean they're an adult or they're not going to understand how to be treated in terms of substance treatment as an adult. So we need to be careful about that. But yeah, they can catch up. They're just going to be behind for a bit in terms of learning how to make those connections cognitively and emotionally.
All right, thank you for answering that question. All right, so it looks like it is 10:53 right now. Um, are you good with taking a 7-minute break and everybody can be back at 11?
Yeah, that's perfect. So 7 minutes. Thank you.
All right, see y'all soon. All right, so it is 11 o'clock, and everyone's gonna start filtering back in from break. I actually did not give a shout out to the Children's Trust Fund of Alabama when I was first giving my shout outs at the beginning of the presentation. But we have our officer who's over our grants that we have with CTF on today. And we just wanted to give CTF a shout out and thank you for everything that you do to help us do prevention work. CTF, like I said, is the Children's Trust Fund of Alabama, and they actually work to reduce child abuse and neglect. And one of the things they focus on is healthy families and healthy children. So doing prevention work and educating families, educating children on the effects of substance use is something that is very important to them. It's also very important to APC, and we really could not do that without them. So let's see, we have about an hour left. Dr. Savage, you can go ahead and start with part 2 of the presentation, and then we will take questions, I guess, towards the end.
Okay, I do see one question in the Q&A. Should I do that now, or I guess we can, and then we'll start into it. But there's a question in the question and answer about a 15-year-old student is diagnosed with oppositional defiant disorder. From the parent's perspective, they can't tell their child no, or it will lead to the kid becoming angry and potentially violent. Or we'll say, quote, kids will be kids. However, this child is getting deeper into doing drugs, dealing drugs, mentions gang activities. How do you approach that conversation with parents as a teacher? Yeah, that's a tough situation. My thoughts are that the child definitely needs some level of treatment in terms of counseling. And I know that a lot of these kids just refuse to go to counseling, and that's when again you get into a pickle. And then the other end of the spectrum is if the child's ever violent, like this says potentially violent, but the child has been violent or harmed anybody else, including himself or herself, that they should just be instructed to go to the emergency department. And so that's the other piece of advice I give. Sometimes, if a kid's behavior is so out of control, especially if there's drugs involved, and it says in here dealing drugs and gang activities, sometimes I've actually advised parents to call to get a legal side of things involved on, well, even without charges. Like there's a program in Jefferson County. Oh goodness, I'm probably forgetting the name. It's like it's not LEAP. It's something. It's a program where you can be paired with a probation officer, but without charges, in order to help get resources to young people who have problems like this, um, before they do get a charge that ends them in jail. So and I know Jefferson County has a program, some other counties do. There are some other treatment programs in the state that come to mind, like Pathways is a treatment program for oppositional defiant and psychiatric disorders and children like this, that you can send them there. Even if they refuse, they can still be mandated to go there. Um, so I talk about things like that. So again, I've had a couple of families actually get the courts involved with a patient just because their behavior was so out of control and potentially harmful. If the police have to get involved, sometimes the police get involved. So, um, but I would frame everything in the context of health and safety again with the parents and letting them understand that he can't continue these behaviors because they're harmful to him and other people.
And it looks like in the chat, a couple people have said chins, which
Thank you. You got it. Chins.
I believe stands for children or child in need of supervision. And back from when I worked with juvenile court, most parents could just contact the juvenile probation office and be connected with someone that can kind of guide them through that process.
Yeah, that's perfect. Thank you. Sorry, lots of four-letter acronyms in my clinic. And I just had a patient recently involved with Chin, so and I couldn't remember. Um, anyway, these are hard. Like, and that's part two of this presentation actually, is that this first sentence, things can get complex. That's to say the least, and complicated. But just keep walking together with your patient, your student, your client. I have to think of it that way, y'all, because it does get so complicated and tough, and these kids are sick and they're not motivated in many cases to get better. Um, they don't understand again, and I know it's part of it is cognitive development, frontal lobe processing. They don't quite understand why we're so concerned, and so they don't make decisions on their own behalf, and that's why the family's so vital to treatment. But again, you got to get the families to buy in 100%, right? Or nothing gets followed up on. So I appreciate the questions, but this last one about how do you talk to the parent? Because yeah, you got to get the parent to buy into what we're recommending for change to happen, and know that they've got the tough job, right? They've got to follow through and work with the kid. Um, okay, so let's talk about some cases. Let's see. All right, I'm just going to go through 3 or 4 case examples, and maybe I'll give time after each one to talk about it. I want to get through all of them to talk about each kind of scenario. So just bear with me with all the text on the page, but I'm going to try to read through this, okay? So there's a 17-year-old who comes into my clinic for a checkup. He has trouble sleeping and he uses marijuana to help with his sleep nightly. He uses marijuana in the form of dab pens. He admits to vaping Delta 8, and he smokes the dried marijuana as well with a gravity bong, which is how most kids that I hear smoke it, honestly. So they're blunts or grav bongs, or however you say it. His biological mom, on family history, has alcohol problems, and she's in recovery. The patient has seen a counselor for anxiety over the past 9 months, so he's already connected with a counselor. He also has ADHD, so he takes Adderall XR for that. He has a girlfriend who smokes marijuana as well. Um, he plays on the soccer team still. He admits that he sometimes takes extra ADHD meds because his mom takes ADHD meds, and he's used a few of her pills in the past when you ask him confidentially. So when you read all this, my mind goes to what are the risk factors? What are the protective factors in his risk of substance use disorder? What do we need to do in terms of how to help him, right? Just knowing that he smokes marijuana daily, like I told you guys on the beginning of the talk, if anybody uses anything daily, they probably have a severe substance use disorder for that substance. So then that's usually a referral for treatment, or some level of intervention for drug use, depending on the motivation of the child. So here's like a couple of slides on marijuana, and I know I've sort of talked about marijuana at the beginning as well because it's such a common thing we see in these youth. And again, many youth feel it's safe and healthy and good to use. But there's multiple ways to use it, and I've seen it, and here, look in the middle here at this column: smoked, inhaled, orally ingested, or transdermal. I've never seen a kid with transdermal, even though I know that we don't have quite as many products as like California, Colorado, other states have, but I know this is probably coming more here, but definitely see smoked through, bongs, pipes, bowls. Inhaled is what makes me more worried, with dab pens and vaporizers for marijuanas that look like similar to nicotine vape pens, um, but they are a little different because they use THC oil. Um, the issue with dabs and THC pens and is that the concentration of THC can be quite high, much higher than smoking it from the dried plant, and that leads to more addiction potential and more psychosis as well that's ongoing. So oral ingestion is also a thing. Like I mentioned at the beginning of the talk, I had a 15-year-old patient recently admitted for ingesting other things, but she used edibles, and I've heard edibles come up weekly now for the past 2 months in patients when I hadn't heard it at all last year. So I think we're just seeing more products out there in Alabama. Y'all might be hearing about edibles more than me. I just, it's always interesting to hear what the new thing is that kids are using. Um, but okay, so I think it's misunderstood is my point with marijuana, and I threw up some pictures of dab like wax. You know, they use the resin from the plant and they melt it down and make this wax, and then the wax goes into a pen and then it's vaporized and it's called a dab pen. This says CBD oil drops, but CBD is not regulated by the FDA, so most CBD products have THC. Um, so THC is the psychoactive chemical in marijuana. So again, I've talked about it already, how concerned I am about adolescent brain development and THC and how negative it can affect it. So we just have to educate and educate and educate and advocate um, to avoid getting these things in the hands of our kids. So this child, again, the things to ask about in this young man, who I believe was 16 or 17, uses marijuana daily, has a history of ADHD. He's used a few ADHD meds without permission, like from his mom, despite being medicated. He has a counselor. Factors to consider when I'm seeing this kid in clinic are what I've already told you. The fact he uses cannabis every day is a big red flag that probably means he needs more help than what he's currently getting. Asking him about any negative consequences of marijuana use. Most kids would say no, even if there have been some. Sometimes you have to use motivational interviewing techniques right here, which is like open-ended questions, reflections, where literally you take the words out of their mouth and you repeat it back to them, and you reflect what they say sometimes, and try to hear change talk when there might be none there. A lot of times I ask questions like this: what's your motivation to change on a scale of 1 to 10? If 10 is like, I want to quit marijuana today, I'm done with this, and a 1 is like, I have no desire to quit and I really don't want to talk about it, where are you on that scale? And I make them tell me, scale of 1 to 10. So most of the time they pick a number over 1, and you can ask, a lot of times it's more like 2 or 3, it's not very high. But if they say 3 is my motivation to quit marijuana out of 10, then you say, why did you pick 3 and not a 1 or a 2? And that makes them, they have to tell you why they picked it toward 10, right? So they have to tell you some change talk is going to be whatever comes out of their mouth, and then you reflect back that change talk. Change talk meaning some negative consequence of using, or some, like, sometimes they'll say, well, it costs too much, I can tell it affects my breathing. Well, I'm not my mom's told me I need to quit, and I'm like, oh, so your mom's told you need to quit. And you just like, wait, or your mom's told you, your mom seems to be worried about it, why do you think that is? And saying things like that. So we spend a lot of time like this in discussions with teenagers, because we really want to get at, how do we help you make a goal to cut down, because, or to stop if they're willing, but but that's where we're going with this. So this here, motivation for using. So this kid's using marijuana, he says, at night to help him sleep. And so I dig there usually and be like, tell me more about your sleep problems. How long have you been using marijuana every night? Ask about what age they started, how often they've been using daily, and then tell me about the sleep problems. And is it anxiety that needs to be better treated? Is it his ADHD's out of control? Is he even using his medication correctly? I'm trying to find how I can help support him medically, and then with counseling as well, with medications that I know I know what they are. I know they don't alter brain development, instead of him using marijuana as his medication, right? Because a lot of these kids view marijuana as medication when they're smoking it or using it in high concentrations. They don't understand the issues with the brain and marijuana. So for this child, I ask about if I can talk to his mom about my concerns. Not all of them want me to share with mom or dad or whoever's there, grandma. Um, but most allow some level of discussion to occur with their parent about my concerns about their drug use. And that's when I say, this is what I need to talk to them about. I need to talk about how marijuana can negatively affect you, and I'm worried about this or that. Um, what part of that do you want me to leave out? Like, is there a friend that's implicated that you want to make sure I don't talk about? Because I ask if they have issues with you sharing with their parent, I usually ask, what is it about the situation that specifically you're worried about me sharing? And I usually tell them this is how I'm going to say it and try to frame it that way. Like I don't divulge everything, and I'm careful not to divulge anything they tell me not to, unless they're at risk of harm. You know, if they're going to get hurt because they're driving or drinking, things like that, I have to kind of step in there. But um, so other things about this kid, we wanted, you know, as from a psychology perspective, and we have psychology in our clinic a lot of times, so they help us with some of this, is they look really at the psychosocial environment. Like if for a kid who we need to cut back or we want to help him cut back on marijuana, well, what does his family environment look like? Like is he in a household where parents are all smoking it too? You know, that's a huge barrier, obviously. That's going to require a lot of education. Again, do the parents know? How can we involve the parents? I already talked about the patient and family's level of insight into the problem. You know, we have to assess that. Is the kid ready to change at all? And this is this third bullet here that I'm kind of running under here at the mouse is what I've already kind of talked about. I'm always looking for how to set a goal because I'm trying to help keep you accountable to being healthier and being safe and getting you to your goal. Like a lot of kids have a goal of completing high school or doing well in soccer or doing whatever it is. And I frame everything in the context of I want to get you there. I want to get you doing the things you want to do with your life. I'm trying to, marijuana is not going to help you get there, So let's talk about how to get you there. And then therapy, is therapy going on? Do we need to help connect to therapists, etc.? Is there any suicidality? We always ask about suicidality in just about every single patient we see. So this kid, going back to him, his depression and anxiety scales were elevated. So we give PHQ-9 and GAD-7 are two examples of scales, and they were both high. And he wasn't on a medication for depression or anxiety, but we actually started an SSRI that day. And an SSRI stands for selective serotonin reuptake inhibitor. And it's a medication like fluoxetine, sertraline, escitalopram. Those are three examples of ones I use a lot. They're just antidepressant medications. They also help with anxiety disorder. We told him to continue counseling, and I do this a lot. I got him to sign a release to where me and the counselor can connect on what he's sharing with me so that we can all be on the same page. I feel like a lot of times in my clinic, I've become sort of a quarterback for all the other treatment providers. So I'm trying to make phone calls between people to understand so that when he comes in next, I know what his counselor is thinking. I know what his school nurse, sometimes we have to get schools involved as well. And it's tough to get all these people on a conversation together to know, but I think being on the same page as a treatment team is imperative because families hear different things from different people and then they get confused and they give up. So anyway, I had him sign a release so I could talk to his counselor. We talked about cannabis and brain development and why we were concerned. He made a goal to cut down to only using on the weekends, which for him, using nightly to use on the weekends, I'll take it. Okay, all right, let's do it, and let's have you come back in a month. And preliminarily, we said, we're going to see how you do, but we want to talk about referring you to a substance use treatment, like a higher level of care, LOC's level of care, if he was not able to improve or cut down on his use because of reasons that a lot of times it takes that. So that's another takeaway from my experience, and y'all might have some other experiences that work, but with teenagers, they tell me so many times, um, I'm good. I'm not hooked on this stuff. I can quit whenever I want. I'm not addicted. They get hung up on the addiction word, which I don't even use addiction as a word with them because there's so much stigma in teens against that too. Like, or they have a negative connotation where they're out of control if they're addicted, if they're addicted and all teens can quit anytime they want. Um, so I challenge them on that. If they say that, I'm like, okay, awesome. So let's set a goal to cut down and like let's see if we can help you do that. Like we're gonna start your new medicine to help you with your mood and hopefully it'll help your sleep. And then if you can cut down, let's do it. Let's give it a trial run before we talk about getting you more help for substance use. And then we see how it goes. And we use that as kind of a leverage point. So here's one little new tidbit. There's one or two studies out there now about this vitamin. It's like a vitamin called N-acetylcysteine, NAC, N-acetylcysteine, that is being used in adolescents with severe cannabis use disorder. It's like a vitamin you could even get at like GNC or vitamin shops. Um, a group, the addiction medicine group in Boston that does pediatric addiction, they're using it in almost all their severe cannabis patients. And I've had now a couple of patients I've recommended and I've prescribed it to. So we discussed that as an option. We didn't start it yet, but again, yesterday I saw a different kid who actually did start it. It's twice a day. Again, it's a medication for like a vitamin. That we use for Tylenol overdose. There's kind of an odd overlap there, but I just want to throw that out as kind of a new thing in case you guys see more about that in the future. Let's keep going. So here's the second case. Should I stop? Does somebody have a question about the first case?
Yeah, so one of the questions in the chat, which I think you already, well, excuse me, in the Q&A box, which you already answered, is if you would need to get a release of information to contact the counselor that the patient in the case is seeing. And I believe you said yes to that, and you try to work with not only their counselor, but also like their school nurse, if necessary, as well.
Yeah, I think anybody involved in caring for the patient. I'm trying to coordinate. I do have to get a release, and sometimes that gets to be a barrier. To be honest with you, like because of all the back and forth of emailing and faxing, and But I think it's necessary to everybody for everybody to be on the same page and have one message. So it's just hard because we're all busy, and it's hard to coordinate that sometimes.
All right, and we have one more great question. If the parents are modeling the behavior, how do we suggest getting them involved? So I'm assuming just the way I read that question is if they're also actively using
Yeah.
substances, how do you suggest getting them involved? And I know this is one that you run into often.
Oy, oy, oy. Yeah, it's tough. Like it's I have different patients in different settings. I'll put it this way. So like the vast majority of patients I have here in clinic, I have time to sit down face to face with parents with a mask on. I say that because that frustrates me still because it's hard to connect with somebody still, honestly, to me with a mask on. But um, I have time to sit down with a parent by themselves and be like, these are the reasons why I'm worried. And like, I feel like a face to face, eyeball conversation makes a lot more of an impact than just like a phone call where you're leaving voicemails and you're talking on the phone. Because I have some kids in other clinic settings I work in that I can't meet with their parent in person, so I have to base it off a phone call, and that's so different. But but I think a sit down conversation to discuss this with parents to be like, this marijuana use, whatever it is, substance use, alcohol use, is really causing these problems. And I think you have brought your child here because you agree that there are some things that need to improve. And so I'm recommending that whatever we can do to make the environment safer and healthier for them and to help them succeed is what I'm going to recommend because I'm basing it off my care of this person. So I'm really, there's um, it, God, it's tough. I go back, if it's marijuana, let's say, I go back to brain development to try to convince parents all the time. I talk about why the adolescent brain is so different than the adult brain with marijuana. And so even anything we can do to help him to stay away from it would be best. And a lot of times getting it out of his environment is one of the best ways. And if that means that people at home need to not smoke in front of him and around him, then that's something we need to talk about. How can I help you? Like we have more resources for nicotine to help parents and caregivers because like, Alabama Quit Line, I'll get there in the next case. They see all ages, or they can connect with. We can give resource. I feel like we just have more resources for parents to help them quit nicotine. But parents to help quit marijuana or alcohol or help stop or get these things out of the home, to help with counseling with that. I don't have as many resources. I can send them to an adult counselor. I can try to help connect them with adult resources, but and that might be part of the discussion. But I kind of plant the seed in the parent's brain, and I think it takes time for most parents to kind of think about it and see it and understand. Like, wait a second, this is going to be tough for my kid to improve if this is going on. So that's why I said this is complex and you keep walking. You have to keep walking together and just keep the rapport, the connection with the family. The families and I, like, we understand each other better after, 2, 3 visits where we know each other. You can have a lot better conversations when you get to know this family and you're kind of, y'all are buying in to the relationship. So, okay, I'll keep going for this next case. So, 17-year-old comes to clinic for a physical. She has had a difficult senior year and she's afraid she might fail her math class. Um, so she's getting her checkup from you. She's afraid because her grades have been worse. But she also asks while she's there to be screened for STIs, sexually transmitted infections. On a separate interview, her mom shares that she found a jewel in her backpack a few months ago. So that's one of a vape pen. And mom's worried she's vaping. So mom shares that in the separate room, like when you talk to mom separately. The patient admits that she is using a vape pen multiple times throughout the day, and she's been doing it daily for 2 years. She otherwise has used alcohol twice in the past 6 months, and both times she got drunk. Um, and she has smoked marijuana once in the past 6 months. She did the craft screen that I discussed earlier, and she got a 2, which is the cutoff for the higher risk, right? And then she says that she feels irritable almost every morning and has trouble focusing on her schoolwork. She happens to have math first period. So, um, this is my case about nicotine. I already mentioned that nicotine withdrawal includes irritability, frustration, anxiety, difficulty concentrating, mood changes, insomnia, all the things that teenagers complain of anyway, and all the other conditions teenagers deal with mental health wise. So all I'm throwing out there to you all and to all my medical colleagues here, I talk about this a lot, is to just keep nicotine withdrawal in your mind. And because you can use it in counseling your patient and trying to motivate them to cut down on it or um, or pick up some treatment for it, which I'll talk about. This is from a really cool tobacco prevention toolkit at Stanford, and it has this weird. I got the slide from Stanford, but trying to get it to fill in here. Okay, so these are different kinds of nicotine vape products. Well, this is a cigarette pack, and how much nicotine's in a pack of cigarettes. And this is things that again, you guys, I'm sure have heard if you're seeing adolescents, because of how often adolescents use these things. Juuls, I haven't heard of a patient using a Juul in a really long time. A long time, probably about a year, was when this case happened. But Juul pods were big, a couple years ago, and they're equivalent to about 41 cigarettes in one pod. But now there's puff bars that I hear some of my kids have, and that's equivalent to 50 cigarettes in one, 50 milligrams of nicotine. And these Swarm pods are just out of control here. And I just bring this up to say that like all pod units have really high levels of nicotine. Um, so, um, so how to treat nicotine use disorder? Well, we know that in teenagers, okay, I'm framing this from an adolescent perspective. With teenagers, motivational interventions like social media and apps, motivational interviewing in the office, they've all shown improvement in quit rates. And actually, in adolescence, just asking about his willingness or her willingness to cut down improves their likelihood of quitting. So, us as adults in their lives who care for them, if we are asking about them cutting down and concerned about their nicotine use, that improves quit rates. So again, don't feel like just because they tell you no, I'm not stopping, like just you talking about it has helped them increase their motivation. So the American Academy of Pediatrics has an awesome tobacco cessation toolkit as well as the Stanford toolkit. And I pulled this slide from a talk I gave recently for pediatricians, um, but elements of a quit plan for a young person need to include a recommendation to quit completely. And there's this little phrase that they recommend you can say. There's a text-based support, quit support at this number, and a counselor follows up. This is not the Alabama Quit Now line that public health department does. This is a different national thing that resource, but making a recommendation to quit, identifying the triggers to use, which is usually anxiety, and almost every kid who I've talked to said it helps them calm down. And again, my mindset is tell me more about the anxiety. How long has that been happening? Has it been happening just since you've been using? Was it happening before you started using? Trying to understand, do we need do you have a counselor? How do I connect you? Do you need a medication for anxiety? That's all, those are where that's where my brain goes immediately. But identify triggers for use and try to help them brainstorm other coping strategies instead of hitting the vape. Treat their withdrawal symptoms and cravings. I'll get to that on the next slide. Social support, meaning ask if you can involve a loved one, someone to keep them accountable, a friend who will also quit with them, anything that they'll give you there to help them. And then how to care for them otherwise in terms of this is getting into coping, therapeutic type approaches to help avoid vaping. So what are the medications to treat nicotine use disorder? So there are no FDA approved meds to help with nicotine addiction under 18. So anything for under 18-year-old for kids you guys see in schools or otherwise has to have a prescription unless the parent buys it out of pocket for themselves and then they provide it to the child, which does happen a good amount of the time in my patients. But um, what are the options? So the recommended medication for nicotine use disorder in teens is nicotine replacement. So it's gums, nicotine patches, lozenges, and then again there's also a little nicotine inhaler. I never have prescribed this for a teenager. Nasal spray, and then there are two medications that are approved for 18 and up. One is bupropion, also known as Wellbutrin. One is varenicline, also known as Chantix. Um, Chantix works great in adults. It just has like zero studies in under 18, so it's just really hard. I just haven't ever seen a young person on Chantix younger than 18 or 18 or younger. The bupropion would depend on the patient's situation as for whether or not to try that. There's some side effects of bupropion that are concerning, like appetite loss, insomnia. I mean, so you have to be careful doing that. So I end up using nicotine replacement a good bit. And of course, treating the anxiety or depression or whatever that maybe hasn't been treated yet that we need to talk about. Um, so this patient is 7 out of 10 on motivation to cut down on nicotine. And she does have withdrawal and she does crave it when she doesn't use it. Like if she goes, she said, if I go like 2 days on a trip once with my family over the weekend, I didn't bring it and I just felt bad and I really wanted it the whole time. So I actually prescribed nicotine replacement therapy, which is what NRT stands for, and a 21 milligram patch to use every day, and then nicotine gum 4 milligram gum to use every 2 hours is needed for cravings and for withdrawal symptoms in between. Um, You typically do have to have the parent on board for this, by the way, as you can imagine. It's any prescription you send or anything that might need to be paid, any kid using a medication or a gum, the parent's going to need to know. So that's again, she was willing to let me talk to parent about it, and parent knew that she had been vaping anyway, so we had that discussion together. Um, she actually denied any depression, anxiety, trauma history, any other red flags for needing mental health counseling or other meds. So we just stuck with this as the plan. And she came back in a month to see how it was going just for the nicotine. So she came back in a month to talk about nicotine, and then she opened up more about her binge drinking, which she didn't tell the truth about on the first visit, which is okay, happens a lot. Didn't tell me she was binge drinking as much as she actually was. She says it's at least every other weekend, if not every weekend, she's drinking alcohol until she's drunk. So binge drinking definition is 4 standard drinks in within like a 2 hour period for a female, 5 standard drinks for a male. And I say standard drink because the amount of alcohol in most mixed drinks is much more than just a standard. So standard drink's like a ounce and a half of liquor, I believe, like 4 ounces of wine, So I'm just making the point that like I usually just ask to get at binge drinking. I ask if they drink enough to be intoxicated or drunk. Um, you can ask quantity as well, but most kids would drink one drink, but it's like a mixed drink that's in a cup that's really 3 or 4 drinks in one cup. Um, so she's gotten drunk a few times per month, and she's actually had a lot of sexual partners when she's been intoxicated, and not using condoms consistently with most of them, and she denies any sex that was non-consensual that she remembers, even though she was intoxicated at the time. It's just blurry and it's really complex, situation. And she actually tested positive for an STD called chlamydia, which she got treatment for. Um, so, she says she started drinking around 14, and again, it's almost every weekend, and she gets drunk every time now. So there's quite a lot to do here, right? Um, so you keep asking questions. I'm sort of fast forwarding through a lot of things because I also sometimes I'll get psychology or Ashley to help me, understand how severe this alcohol problem is. And she ended up meeting all the criteria for alcohol use disorder at the moderate severity. And she um, she had driven once after drinking. She said she wasn't drunk, but she had drank and driven. And she was first, I tell her, thank you for being so honest with me today. And, I just want to do anything we can to keep you safe. And um, we talked through a plan. And again, this is a multi-visit thing. Like, these visits take so long just to get the history, much less walk through all the education and the treatment plans for some of these complex patients. But the first thing was when you hear about risky alcohol use, you just have to get the family involved to discuss what's going on in order to secure safety. We did refer her to substance use treatment, which here, there's not a lot for adolescents in our state, to say the least. Here's one little takeaway. Like, if you guys are struggling to find somewhere, I myself called the Resource Recovery Center to ask John Bales is the director there. I ask him a lot for help. I also use UAB Beacon Adolescent to help me with assessments and help figuring out where to place people. Also, Bradford has a virtual IOP program. The problem is everything's virtual that's higher level than outpatient. That I know of right now. I mean, hopefully that'll be changing soon. There might be one program I heard about recently in Shelby County that's in-person IOP. That's one thing. It's always changing, and I'm always trying to find places. So if you guys want to email me, if you like work at a program, you're like, oh, I see adolescents for IOP or anything. If you're a therapist and you see adolescents for any level of care, give me an email, please. Like, and I will add you to my list. But um, I'm all because we don't do the work that you guys do, like the actual treatment work, other than coming in, doing medications, meeting with psychology. we don't do the actual substance use treatment in my clinic. Like we try to connect them to that. So anyway, we did that for her. This is my opportunity to talk about medication assisted treatment for alcohol use disorder. I have had a few patients with severe alcohol use disorder that have gotten long acting naltrexone injections for that, also known as Vivitrol. She may meet criteria. That gets into the weeds a little bit. I wanted to just mention that there are medications for alcohol use disorder in addition to naltrexone you could talk about, and sometimes I think about. I don't do a lot of that because intermittent binge drinking is so common. It's not typically a daily thing for most of my kids, but when it gets to be near daily, that's when we're talking about the naltrexone and things like that. Another big takeaway for this example is that she was a very high risk for HIV and other STDs, STIs, sexually transmitted infections. And so we discussed what PrEP was, which PrEP is HIV pre-exposure prophylaxis. Because of time, I knew I wouldn't be able to talk all the details about PrEP, but it's a medication you can give to patients once a day to use. They have to use it daily and take it every day. And it would prevent HIV acquisition if they were having high risk sexual behaviors. There is a great website with very basic information for patients that I love and I share with every patient who I'm talking to about PrEP, and it's this one. Okay, so cdc.gov/HIV/basics/PrEP. Okay, or you can just put in Google or search engine of choice, um, CDC PrEP Basics, CDC HIV PrEP Basics, CDC HIV PrEP, anything like that, and it will come up. And it's great. There's YouTube videos, there's all kinds of stuff. So if you have a patient who is having unprotected sex and has had an STD, and in this kind of situation, PrEP is now recommended for adolescents. So again, that's a whole other lecture, but just wanted y'all to know about that. I'm going to keep going to case 3 for time's sake, just to get through a couple of things here, and then I'll stop. And I'm probably going to skip some slides here because I didn't realize it would take me this long. Like again, sometimes I talk more than I think I will. But this case is a 17-year-old young man who was found unresponsive by his dad. EMS was called and naloxone was given ×2 on the site, and then he was transferred to Children's of Alabama to the ICU. He had multi-organ damage, so multiple organs were affected and damaged because of his essentially an overdose is what happened. His first drug screen here at the ER came back only positive for cannabis. And that's another side note that we need to improve on, which I'll talk about in a minute. He lives with his father for the past few months, only he used to live in a different town, and he takes a medicine for depression. Dad knows he uses marijuana frequently and that he vapes, but Dad had no clue about any other substance use. He was eventually extubated. He had a tube to help him breathe. That got taken out. He went to a step down bed, and he admitted he had been using Perk 30s, is what he called them, daily for 2 years. He never used fentanyl knowingly, even though that was our suspicion. And he was not trying to kill himself, and he still doesn't want to, and he actually would love to go home as soon as possible. So this brings me to medications for opioid use disorder. Again, I didn't talk much about medication-assisted treatment and what it was, but you guys probably know this already, or maybe not. But so medications combined with counseling and behavioral therapies is the approach that in the adult world and now in adolescent world we're trying to take, because we know that medications improve treatment outcomes and death from all causes, including starting at 16 years old. So these are our high schoolers. I mean, this is where we're missing in my opinion. I think we're missing a lot of these kids and getting them into treatment on the medication to help them with opiate use disorder, with alcohol use disorder. We're waiting until they're adults, unfortunately, because there's not as much data until recently. There's been study after study, and they're still happening. that show that adolescents do better in treatment, decrease IV drug use, more negative drug screens if they're on a medicine and they're in counseling together. And so MAT for opioid use disorder is a two-pronged approach for our patient. Let's say this is our patient. It's two things we're talking about here for these patients. It's behavioral treatment and meds. So behavioral treatment includes their counseling, individual counseling, any kind of community or group support, any sort of counseling or behavioral treatment for comorbid psych disorders, but it's also meds. And I don't mean to overwhelm with the amount of text on the slide, but and again, I use this slide from another talk I gave, but I wanted to at least lay out the meds I'm talking about. So there are meds that work at the opioid receptor. This is called buprenorphine or buprenorphine naloxone, which is Suboxone. There are meds that help with withdrawal, like clonidine, which is a blood pressure medicine that sometimes we use. There are SSRIs I've already mentioned that we can add on and use to help with anxiety and depression and trauma symptoms. And then there's overdose prevention, which is hugely important, also known as Narcan or naloxone. So when I'm thinking about patients, I'm thinking in this perspective, like what is the counseling situation, what is the medication situation, and how can we use both to help support this kid the most? So I don't want to get too much in the medical weeds here, but I'm trying to make a point here that there's an opioid receptor in the brain for these kids who use opiates, which are, Percocets, which include oxycodone, hydrocodone, heroin, fentanyl. Just those are all full agonists at the opiate receptor. So you see, like the full pentagon here is bound. Buprenorphine is called a partial agonist, so it binds really strongly. You see, it's got increased binding strength. So it actually, when it comes in your system, it knocks off the full agonist because it binds stronger, but it does not activate the full pentagon here. It doesn't activate and cause the same effects as like a full agonist would. So it works because it binds up your receptors. It has a little bit of like sedation effect for some, and like a little bit of effect you can feel from taking it, but not the full high or the risk of overdose, etc. that like heroin does. And then there are antagonists, which just bind but have no activity at all. That's naloxone. So naloxone binds the strongest of all of these mu opioid receptor meds. That's why it works on site. That EMS gives it. If you've used fentanyl, which this young man did, if you might have to use it 2 or 3 times, but it's going to bind so strongly it knocks off all the fentanyl and buprenorphine from the site. So that's why it works. The problem is it unbinds quicker than this unbinds. So a lot of people go back and get sleepy again and go back into sedation. You have to keep repeating doses, for example. This is also why shots that have naloxone or naltrexone work, because when you give a 30-day injection of this stuff, it's bound up all your opiate receptors. So if you go use an opiate, it doesn't work anymore. It can't bind at the site. So that's why naltrexone shots work. So I'm going to skip a couple slides for the sake of time to talk about what happened to this patient. So he came to my clinic after discharge. He had not used opiates in 4 days since he was sent home from the hospital. He had some withdrawal from opiates 2 days prior, but actually they're getting better. So he'd gotten over the peak of the withdrawal just when he was in the hospital. He wasn't initiated on buprenorphine in the hospital because until now we didn't even have it available, to be honest with you, in the hospital. So that's what happened. He actually still craves perks, he'll admit, but he has not used anything except his nicotine and marijuana. Now you have the drug screen back that shows fentanyl, which is a piece we're trying to work on at Children's with getting fentanyl on our initial drug screens, because the drug screens that test for it take a week to return, which is pretty useless in the moment. But it helped me know, okay, yeah, so we validated that it was fentanyl that caused his overdose. He was open to Suboxone, also known as buprenorphine naloxone. It took me 5 days to get it approved by Alabama Medicaid, which is another barrier. He initiated at home with dad's supervision. He ended up on one 8 milligram strip of Suboxone twice a day as his goal dose, but he never got there because he was quite sedated with the full strip. He was open to trying a virtual adolescent IOP program, which was the only, there's no in-person option at the time. This was about a year ago. He continues to take his SSRI. He uses clonidine as needed for withdrawal. And a little bit later, we had to adjust his Suboxone dose, which we have to do quite often for these kids. And dad was monitoring his Suboxone use. So, just a couple of slides on family involvement, and then I'll be quiet because I know we're about done. So I've already talked about how important naloxone is. Overdose prevention is also known as Narcan spray. That hopefully you guys have seen these before. We talk to the parents for patients like this who are very tenuous, who are high risk of using something that could kill them again. That we give a lot of very specific guidance to parents about monitoring cell phone use, not allowing patients to have cash or credit card access while they're, especially in these in this type of situation of this case, for example. Very clear curfew limits, car accessibility and who they're with needs to be strictly discussed and like planned out. And making sure they're doing things to pull their weight, like chores or their job, doing their schoolwork. So parental expectations, we talked through a lot of that. Family education in general, I've talked about this a ton, but one thing I haven't talked about is med storage and monitoring. The vast majority of my patients who use Xanax or any sedatives like that, or opiates or pain pills, they're getting it from a family member. They're not just buying it off the street. They end up buying it off the street after they start using a family member's, and then they run out, then they end up on the street. That's when they overdose on fentanyl, because fentanyl is inside of what are we saying now, like 30% of street drugs or some kind of crazy high number. I've had patients now overdose on fentanyl who were thinking they were using Xanax. So, and we know it's in perks and other oxys and things on the street. So, harm reduction is a huge discussion. Whatever we can do to keep these kids off of street medications is what we need to do, and we're talking about this on a weekly basis. Generally, to parents, I tell them, and this is like, we're done with the case, so let's talk about general advice to parents, is to stay suspicious and ask questions of your kid. Trust your gut. If a parent feels like something's going on, there's probably something going on, and just listen to them and back that up and reassure them and try to help them find the resources they need. Parents need to know before their kid gets old enough to, like in elementary school, that drugs are not this normal rite of passage that every kid does and has to go through, and I did it too. We don't need to look at it that way, because drugs are much, in my opinion, more dangerous than they used to be. Like marijuana is much higher THC. The street drugs all have fentanyl in it. They're causing people to die. I mean, this is nothing to just mess around with. So we don't need to think that it's just a normal thing that kids are using drugs. And if you're concerned, don't be apologetic about finding someone to help you. I have a lot of families come in and say, I'm so worried, I don't know, maybe I shouldn't have looked at. No, like it doesn't matter how early it is, like the earlier the better to get help. So in summary, adolescents are a special population that are best served by a treatment team that includes multiple members: healthcare professionals, psychosocial supports, and family, and the teen. The teen is the most important piece of making some of these decisions. But sometimes we have to take autonomy away from the teen when they're at their sickest and help them get better. Medications and behavioral therapies are standard of care for adolescent substance use disorders, and harm reduction strategies are vital as well. Narcan, PrEP, the things like that I've talked about. These are my kids this has been a year ago. They're kind of older now, but this is like awkward family photo just for smiles at the end. I don't They took like this awkward photo at school. But y'all, this is my clinic name. It's Adolescent Help Center Children's. My clinic number. I'm most responsive to email, so please email me with anything at all.
All right, Dr. Savage, thank you, thank you so much. Thanks for this presentation, and also thank you so much for taking care of our kids. I know this is a difficult topic to address for parents and youngins, so I appreciate you for doing the great work.